This 3D sagittal diagram illustrates William Prophet's equilibrium theory. In a normal pediatric oral cavity, tooth position is maintained by a strict balance of forces. The outward pressure of the tongue is perfectly neutralized by the inward pressure of the lips and cheeks. When a thumb enters this space, the balanced vector arrows aggressively shift toward the anterior teeth and the palatal vault. The physical tissue must respond to this new pressure map. The upper arch constricts into a V shape, the anterior teeth procline outward, and an anterior open bite forms. Non-nutritive sucking is a normal adaptive behavior in infants. In most cases, it resolves on its own by 3 or 4 years of age without causing permanent damage. When the behavior persists past this window, the etiology often becomes psychological. Sigmund Freud theorized that these habits stem from insufficient gratification during the oral phase of psychosexual development. Clinicians rely on a specific metric to determine when this psychology crosses into pathology. It's called the 4-4-4 rule. Intervention is required if a child sucks their thumb for more than 4 hours a day, is older than 4 years of age, and exhibits 4 or more clinical signs of malocclusion. The severity of that resulting malocclusion is dictated by Graeber's triad. This model calculates tissue damage based on the habit's duration, frequency, and intensity. Duration is the primary driver. A physical force applied to the dentition for more than 6 hours a day will move teeth, regardless of how light the pressure is. Modern appliances function as engineered biomechanical tools, designed to break pathological force durations and restore natural oral equilibrium. The standard frontline intervention for a persistent digit-sucking habit is the fixed palatal crib. The objective is not to cause pain. The appliance acts strictly as a physical barrier that breaks the palatal vacuum seal, removing the proprioceptive pleasure of the habit. Looking at the hardware in this diagram, you can see bands cemented to the maxillary first permanent molars. A 0.036-inch stainless steel wire spans the palate, with smooth vertical spurs hanging down directly behind the upper incisors. This barrier prevents further tissue damage. However, it cannot correct the arch if the habit has already caused a constricted maxilla and a posterior crossbite. To solve this compound problem, clinicians integrate a quad helix expansion appliance into the palatal vault alongside the anterior cribs. This dual-function tool provides a slow, outward transverse expansion to correct the crossbite, while the anterior barrier blocks the digit. Clinicians sometimes attempt this using removable palatal cribs mounted on Holly retainers, but these fail frequently due to patient noncompliance. The decision between a simple fixed crib and a combined quad helix appliance rests on identifying whether the transverse dimension of the patient's maxilla has already collapsed. Historically, the approach to breaking these habits relied on aversive therapy, utilizing sharp, downward-pointing tools like the hay rake appliance. The dental community abandoned these aversive tools because inflicting pain creates psychological trauma and resistance, which directly drives high relapse rates once the appliance is removed. Modern clinical standards prioritize proprioceptive retraining. Here on the left, you see the punitive downward vectors of the traditional hay rake. On the right is its replacement, the bluegrass appliance, developed by Haskell and Mink. The defining feature of the bluegrass appliance is a free-spinning Teflon hexagonal bead suspended in the palatal vault. This mechanism utilizes positive reinforcement. It provides a substitute oral gratification, encouraging the child to roll the bead backward with their tongue instead of sucking their thumb. Beyond habit breaking, this rolling action delivers a secondary myofunctional benefit. It retrains the tongue to rest in its correct physiological posture against the incisive papilla. Long-term habit cessation is most successfully achieved by redirecting the child's neuromuscular energy toward positive sensory feedback, rather than punishing them with physical barriers. In the lower arch, we encounter the lip trap phenomenon. This occurs when a hyperactive mentalis muscle causes the lower lip to habitually rest behind already proclined upper incisors. This creates a vicious biomechanical cycle. The trapped lip exerts outward pressure on the upper teeth, worsening their proclination, while applying inward pressure on the lower teeth, causing retroclination and crowding. The hardware engineered to break this cycle is the lip bumper. This diagram of the mandibular arch shows the heavy wire anchored to the first permanent molars via buccal tubes. The critical feature is its precise anatomical standoff. The wire and its acrylic shield run along the labial vestibule, strictly maintained 2 to 3 millimeters away from the lower incisors. The appliance operates as an external shield. It absorbs the abnormal muscle pressure from the lip and transfers those forces directly back to the molars, leaving the anterior teeth entirely untouched. Isolating the teeth from the lip creates a secondary orthodontic benefit. Without the restrictive inward pressure, normal outward tongue pressure causes the lower incisors to spontaneous uprighting. This spontaneous uprighting routinely yields 1 to 3 millimeters of vital arch length, which helps resolve lower anterior crowding. By neutralizing abnormal soft tissue forces with a bumper, the clinician allows the patient's functional equilibrium to organically expand and align the lower arch. Respiratory habits present a different set of challenges. Chronic mouth breathing generates severe developmental consequences, including adenoid facies, long face syndrome, and a narrow V-shaped maxilla. Treating this presents the most critical diagnostic trap in pedodontics, confusing habitual mouth breathing with anatomical, obstructive mouth breathing. Clinicians must conduct precise diagnostic evaluations, such as the mirror fog test, Maslow's water holding test, or objective rhinomanometry. This leads to an absolute clinical rule. Intraoral appliance therapy is strictly contraindicated until an ENT specialist rules out or removes physical obstructions, like enlarged adenoids or a deviated septum. Once a case is confirmed as purely habitual, the proper appliance is the oral screen or vestibular shield. This sagittal view illustrates the acrylic screen fitted perfectly into the labial vestibule, forming a complete seal against the lips. This design applies Frankel's physiological concept. The shield physically blocks oral airflow, forcing mandatory nasal breathing. Simultaneously, it provides a rigid surface for lip exercises to strengthen the orbicularis oris muscle. There is also a secondary functional benefit. Attempted mouth breathing against the sealed screen creates an intraoral negative pressure, which stimulates palatal expansion. Prescribing a vestibular shield without clearing the anatomical airway is dangerous negligence. Applied correctly to a habitual breather, it is a powerful tool to retrain the entire respiratory musculature. Managing any of these habits requires adhering to a strict stepwise management protocol. Hardware is never the first line of defense. Steps 1 and 2 dictate that therapy must begin with psychological counseling, positive reinforcement, and reminder therapies, such as bitter-tasting nail polish. This conservative observation period lasts 3 to 6 months. Step 3 moves to appliance therapy. This is strictly reserved for tractable habits that fail to resolve after the initial 3 to 6 month window. When selecting the appliance, the evidence base provides clear direction. According to the Cochrane Systematic Review by Borey and colleagues, fixed palatal appliances statistically outperform removable modifications simply by removing the variable of patient compliance. However, even the correct appliance will fail if it is removed prematurely. To prevent this, clinicians follow Graeber's strict retention rule. The appliance must remain cemented for a minimum of 6 months after complete cessation of the habit. This post-cessation phase prevents neuromuscular relapse, allowing the brain to permanently overwrite the ingrained motor pattern. Interceptive orthodontics utilizes specific biomechanical hardware to neutralize pathological forces, allowing natural, self-correcting dentofacial growth to take over.